All right, you guys, we are recording this lecture. So, no burning questions? Yes, you do.
Yeah, I do on the practice exam.
Yeah.
Question 25.
Sure. Yeah, just read it to me. Yes. Okay, yeah. Okay, so the question is number 25. Which of the following would reduce the total oxygen content of the arterial blood the most? Okay, so we talked about hemoglobin, and we talked about the partial pressure of oxygen, solubilized oxygen. First of all, which is going to have a greater effect when we're talking about total oxygen delivery or levels of oxygen in the arteries? Yeah. So first of all, you should know that any effects on hemoglobin, because that accounts for 98% of oxygen transport in the blood, if you're going to affect hemoglobin, that's going to have the greatest effect on arterial oxygen levels. So it wouldn't really be a decrease in PO2. It would not be a decrease in the partial pressure of carbon dioxide. And mean arterial pressure, that doesn't make any sense at all, okay? So it's really going to be a decrease in hemoglobin concentration by 50%. That's going to have the most effect on the total oxygen content in the arteries, okay? Okay, so let's go ahead and start with lecture 14. A lot of it is anatomy right off the bat. So I'll tell you some of the diagrams that I need you to know. Okay, open up 15 here too. Okay. Okay, so the first part is anatomy. And I would say the one that I want you to really understand is this one, okay? So be prepared to label this particular diagram, and what I want you guys to mainly focus on is the conducting zone and the respiratory zone. So the conducting zone is the part of the respiratory system that does not participate in gas exchange. What else would we call this? Dead space. Specifically, anatomical dead space. Perfect. Okay, so that's important to understand. The only way you're going to change anatomical dead space is by tubing somebody, like when you're in surgery. Under anesthesia, you have a tube down your throat. The anesthesiologist needs to be very cognizant of that increase in anatomical dead space, and to keep alveolar ventilation in normal ranges, they have to adjust the respiratory rate. Okay? You guys know what I'm talking about? So this equation should come to mind. Alveolar ventilation or VA, right, is equal to tidal volume minus dead space volume. Multiply that by respiratory rate. Minute ventilation is equal to tidal volume times respiratory rate. This is analogous to cardiac output is equal to stroke volume times heart rate. So they're both flows in mils per minute. So what you have in the conducting zone is the trachea to the two bronchi and the terminal bronchioles, right? And then you have respiratory bronchioles in the respiratory zone, respiratory bronchioles, alveolar ducts, and alveolar sacs. Okay? Okay. The next thing that's really important is surfactant. Okay? So I want to make sure that everybody kind of understands what surfactant is all about. I think this table is the best one to look at. There are a couple of questions on surfactant. So I want you to realize that surfactant is a mixture of phospholipids and proteins. The main thing is it's secreted by the alveolar type 2 cells, not the type 1, but the alveolar type 2. So what does it do? It actually reduces surface tension, particularly in the smaller alveoli. And it increases compliance. So compliance, another way to think about compliance is the stretchability of those alveoli. So it lowers surface tension and increases lung compliance. It has more of an effect on the smaller alveoli. When you breathe in deeply, the stretch of those alveolar type 2 cells causes a secretion of surfactant. So always good to stand up, you know, after you've been sleeping all night in a horizontal position, stand up, take in a deep breath. That'll actually help with breathing because of the release of surfactant. And remember, the reason why infants, I would say newborns that were born prematurely, right around the 26-week in utero, usually they have problems with lungs, their respiratory system, because they are not secreting surfactant at that point. Okay? That's why there's a window of time before 24 weeks, especially when they're not secreting surfactant. Usually babies that are born prematurely don't survive. After, I'd say between 24 and 26 weeks, there's some variability. And then later in gestation, surfactant is being produced. Okay, so production in the fetal lung occurs in late gestation. Okay, here's the law of Laplace, and it explains the relationship between surface tension, radius, and pressure. Okay, so pressure at the top there is equal to 2 times surface tension, T, over the radius. Okay, so if you're actually looking at just the smaller alveoli, let's just say that, without surfactant, the surface tension are going to be equal to each other. So the surface tension in A is going to equal the surface tension in B. If you take that into account, if you look at the law of Laplace, the radius in the smaller alveoli is going to be pretty small. So if the surface tension is the same, the pressure is going to be high in the smaller alveoli compared to the larger alveoli. Does that make sense? If that's the case, if the pressure is greater in the smaller alveoli than the larger one, then there's going to be airflow, right? The air is going to flow always from high pressure to low pressure. It's going to go from the smaller alveoli to the larger one. And there's going to be alveolar collapse if there's no surfactant present. All right, but with surfactant, it actually causes the surface tension to be lower in the smaller alveoli. Okay, that tends to equalize the pressure, and now you don't get alveolar collapse. So it allows for more alveoli to stay open when surfactant is present. Okay, so which one of these two scenarios is going to have the greatest amount of alveolar dead space? Is it this scenario, or is it this scenario when surfactant is present? Which one is going to have the greater alveolar dead space? Right. The one without surfactant is going to have more alveolar collapse and a greater amount of alveolar dead space. Okay. So, now I think you guys can answer the surfactant questions pretty well. Then we talked about ventilation. Remember that mammals are negative pressure breathers. That's the main thing. Mammals are negative pressure breathers. What we tend to do is we have neurons that are innervating these external intercostal muscles in between the rib cages. Okay? So when our respiratory neurons stimulate these external intercostal muscles, what it tends to do is pull the ribs out, opens up the thoracic cage, pulling the lungs open, okay, increasing the volume. What that tends to do is decrease the pressure inside the lungs. And then air is always going to flow from high pressure to low pressure. So it's going to pull air in. Does that make sense, you guys? Anybody remember the principle, the law associated with this? You guys remember this? Anybody taken physics? Boyle's law. Perfect. Boyle's law says that if you have a finite compartment, right, and you increase the volume, and you have the same amount of molecules, gas molecules within that compartment, there's going to be less collisions, so it's going to decrease the pressure. If you increase the volume, the pressure is going to decrease. I can guarantee there's going to be something about that gas law. So know that that's Boyle's law. That's called Boyle's law. So how do we exhale? The innervation to the external intercostal muscles stops. Those muscles relax. The ribs and the diaphragm move back to their original position, causing the volume to decrease, which increases the pressure and causes the air to be forced out. Another element to this too is there's an elastic recoil of the lungs as well. So there's two things. The rib cage goes back to its original position, and the lungs are acting like a balloon that you would blow up. There's an elastic recoil that helps to force the air out. Pressure rises, air will always flow from high pressure to low pressure, and it'll be pushed out of the lungs. So we are negative pressure breathers. All right, so if for, there's patients that need help breathing, let's say they've been in a car accident or something like that, you guys have seen those bags, right, that the paramedics use. That's actually positive pressure breathing, okay? It's called PEEP, actually, positive expiratory, I can't remember the name of it, but it's a positive, you're actually forcing, right, when you push on that bag, you're increasing the pressure in the bag and forcing air in. So that's a positive pressure breathers. Frogs are positive pressure breathers. They actually gulp their air. Okay, kind of interesting. All right, so the main thing with this diagram, since you guys are here with the review, I would say is just the definitions at the top. Just know those definitions, okay? The transpulmonary pressure is just the pressure difference across the visceral membrane, that inner membrane. Okay? Transpulmonary pressure is the pressure difference across the visceral pleural membrane. So what it is the alveolar pressure minus the interpleural pressure. Okay? It's technically the pressure that is keeping the lungs open. It's opposing the elastic recoil. Without that pressure, your lungs would collapse. So I'll say that one more time. Transpulmonary pressure is the pressure difference holding the lungs open. It opposes the inward elastic recoil of the lung. The chest wall pressure is the pressure difference across the chest wall. Okay, it's the pressure difference across this chest wall, across the parietal pleural membrane. So it is the intrapleural pressure minus the atmospheric pressure. And it's technically, by definition, it's the pressure difference that is holding the chest wall in. It opposes that natural tendency for the chest wall to bow out. So if you're actually, like I said, looking at a model of a skeleton, like around Halloween or in a biological laboratory, you'll notice that the chest wall always looks like barrel-chested, like way bigger than it should. But that's because naturally, without your muscles and all of these other forces, your chest wall would tend to bow out. So you have all of these, you have this chest wall pressure that helps to keep the chest wall in. Okay? Now, the respiratory system pressure is the pressure difference across the entire respiratory system. It's across the visceral and the parietal pleural membrane. So it is the alveolar pressure minus the atmospheric pressure. And that determines airflow. That's as simple as that. Pressure difference across the entire respiratory system, notice it is usually the same as the driving force for airflow. It is determining airflow in the respiratory system. With this diagram, don't spend so much time on it. Okay, there's not any questions on this diagram. The main thing that I need you to focus on is the definitions, transpulmonary pressure. Which leads us to, okay, Boyle's law, you guys already know that. Back to Ohm's law. Okay, so remember, airflow is just like blood flow, is just like electrons, electrolytes that have charge associated with them. If you rearrange Ohm's law, because Ohm's law states that the driving force equals the flow times resistance. We just rearranged it to say flow is equal to driving force over resistance. So the driving force for airflow is going to be the respiratory system pressure, right? Difference, alveolar pressure minus the atmospheric pressure over the resistance. That's the flow. What about resistance? How do you define resistance? What are some examples of resistance in the airways? Like with asthma. In the laboratory, we actually simulated asthma by making a much smaller hole in that spirometer that we were working with. Yeah. So resistance is the radius of the bronchioles. As you decrease the radius, you actually increase the resistance. Okay, so let's take a look at that. Remember Poiseuille's law. Poiseuille's law actually gives you an idea of how to think about resistance. It's equal, and you guys have seen this already in the exam 2, cardiovascular. Resistance is equal to 8, the length of the vessel. In this case, it's the bronchiole. Length times viscosity. It shouldn't be too viscous, right? Airflow is not so viscous. Over pi r to the 4th. So just like blood vessels, when you make slight changes in the radius, I mean small changes in the radius, either bronchoconstriction or bronchodilation, that translates to huge changes in resistance, right? And this really applies to asthma, basically. A lot of times with asthma, there's two things that are going on. There's bronchoconstriction due to smooth muscle cells around the bronchioles, but also inflammation, which also causes a further constriction within the airways. So those inhalers, albuterol, they're beta-adrenergic agonists, which is the fight or flight response, helps to open up the airways so that they can breathe easier. Okay, so this is just now flow charts. This should be easy to kind of go through. Flow charts that help you think about ventilation. This is inhalation and exhalation. And there's some animations on the Moodle website. Okay, so this is a graph that I think is very important to understand. Now that you know what transpulmonary pressure is, you can read this graph a little bit easier. Compliance is the stretchability of the lungs. We already know that. But now we're going to use an equation. At the very top, compliance is the change in volume over the change in transpulmonary pressure. So it's the relationship between volume and pressure. The green line here is a normal curve. The orange line is more in line with patients that have cystic fibrosis. Okay? So patients that have cystic fibrosis, they have a lot of scar tissue. It's very difficult for them to open up their lungs, right? They have to go to very extreme transpulmonary pressure to just make small changes in volume. So imagine that. You have to really work hard just to get those lungs open, to just make tiny changes in volume. You have to go to extreme transpulmonary pressure. Okay? The blue line is more like emphysema. You would think this would be advantageous, right? Small changes in transpulmonary pressure translates to huge changes in volume. Very easy to open up the lungs. Doesn't take much work at all, right? You don't have to, use much. There's just small changes in transpulmonary pressure translates to huge changes in volume. So it's the difference between blowing up a balloon, right? You guys know a balloon has elastic properties and there's a natural recoil. And blowing up a paper baggie, like a sandwich baggie. Super easy to blow up, but there's no elastic recoil. So the problem with emphysema is actually getting the air out. Okay, they actually have to use their internal intercostal muscles. They have to use their abdominal muscles. They have a very signature breathing, pursed lips. It's actually an excruciating disease. So my lab coordinator a long time ago had a very good friend that had emphysema, and it's excruciating. It's really hard to breathe on a day-to-day basis. So you would think that would be advantageous, but it's not. Yes?
Is emphysema something that's, like, how long does that last?
It pretty much lasts for the rest of your life. So what it is that it's a deterioration of the elastic properties in the lungs. Elastin is the protein. So trypsin is an enzyme that chews up all the elastin, and then once it's gone, you just lost that elastic recoil. So it can't get better. So I don't know if you guys know Johnny Carson. He used to be the old Tonight Show host. It was Jay Leno and then Jimmy Fallon, but way back. So again, my anti-smoking campaign. Smoking leads to emphysema. And Johnny Carson, actually a lot of people didn't know he was a smoker, but he was a chain smoker, and he died of emphysema in the late 80s, early 90s. Yeah. So it's an excruciating disease, yes.
And that's due to, essentially, wouldn't it be due to increased compliance?
Increased compliance.
Okay, so
yes.
Okay.
So the blue line. Blue
Right.
line, emphysema. Orange line, cystic fibrosis.
Okay.
Yep. Okay. All right. So we talked about pneumothorax. There's essentially two types of pneumothorax. One is a breach of the parietal right? Pleural membrane. That was the example that I gave with the snowmobiler that got impaled, right? This would be more of a sucking chest wound. So every time you breathed in and you opened up the thoracic cage, you draw in air from the outside into, and it starts to accumulate in the intrapleural space. Again, an open, sucking chest wound. Okay. A closed pneumothorax, like emphysema, is where there's a breach of the visceral pleural membrane. And every time you breathe in through your lungs, it escapes into the intrapleural space. Another example that I gave is a car crash where you took a deep breath before you hit a steering wheel and it just forced all the air, like breached the air into the pleural sac. And then every time you breathe in, it's going to escape into the pleural sac and air is going to, right, this is usually just fluid filled. Air is going to accumulate with every breath in that intrapleural space until your lung is the size of maybe your fist, right? That's where you would use a needle. You would let all the air out of the pleural sac, and then your lung would expand back to its normal position. That's how people with collapsed lungs, that's how they treat them, okay? So this is what it looks like on an x-ray. You can actually see that the lung has separated from the thoracic wall, and air has accumulated in that space, okay? So you would take a needle and you would try to let all that air out so that the lung can expand back into its normal position. Yes?
Sorry, can you repeat what is breached in an open?
Yep. So in an open, it's the parietal, okay? The visceral membrane, even with the pericardium in the heart, that's going to be the closest to the organ. The parietal one is on the outside. Yep. Yep. All right. Lung volumes, you guys have probably seen this 1,000 times. I like to lecture from this particular slide. Each one of these slides has its own information, a little bit more text, but it's saying pretty much all the same thing. So there's a lot of redundancy in these 3 slides. But this is the one that I want you to know. I want you to know 4 different lung volumes and 4 different lung capacities. I'm not going to give you the equation, so you're going to need to know, you're going to have a lot of information that are information you don't need, right? And then you're going to have to decide what information that you're going to use to calculate the different capacities, okay? So I think we had a practice, there was a question, a practice question, and it was a vital capacity question, correct? So you had tidal volume, you had inspiratory reserve volume, you had expiratory reserve volume, and you had residual volume. And it said calculate vital capacity. You would have to choose which volumes you need to add together to figure out that question. Pretty easy. Just know the capacities are the sum of at least 2 volumes. Capacities are the sum of at least 2 volumes. So the 4 volumes that you need to know is tidal volume. This is the volume of air that you breathe in and out in a normal breath. You don't even think about it. It's usually about 500 mils for a 70 kilogram or a 165 pound person. Now, here's the key to understanding it. Remember, with a tidal volume, when you inhale, right, you're at the top of an inhalation. The inspiratory reserve volume is everything that you can take into your lungs after a normal inhalation. So tidal volume isn't a part of that equation. After a normal inhalation, when you're at the top of that peak, everything you can draw into your lungs is the inspiratory reserve volume. Okay? After a normal exhalation, you're right here, everything that you can blow out of your lungs is called the expiratory reserve volume. And then after you've blown all of the air out of your lungs, luckily for you, you still have some residual volume. Otherwise, your lungs would collapse. Remember, the residual volume is the only volume that you cannot measure with the spirometer. The only way you could measure that, again, is if you take a vacuum cleaner and you suck all that air out and you collapse your lungs and then you measure it. Excruciating. That's why usually what they do is they calculate it. They assume a few things. They know your gender, your height, your weight, and then they make a calculation based on averages. Okay? So vital capacity. Okay, so then the 4 lung capacities. These are the 4 that you need to know. Inspiratory capacity is tidal volume plus inspiratory reserve volume. Functional residual volume, functional residual capacity, FRC, is the expiratory reserve volume plus the residual volume. Okay? Vital capacity is everything you can measure with the spirometer. It's inspiratory reserve volume plus tidal volume plus expiratory reserve volume, everything but the residual volume. And then total lung capacity is all 4 of the volumes added up together. So it should be after a huge maximum inspiration, it should be the entire volume of air in your lungs. All 4 of them, inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. Okay. So on the exam, I'll probably give you information about all 4 lung volumes, and then I'll say something like, calculate functional residual volume. And you'll have to be able to pick out which volumes you need, and then add it up, and then that's your answer. Pretty easy, pretty straightforward. Okay? All right, so now knowing something about conducting zone, that there's a dilution effect is really important. Okay? Anatomic dead space, all of these are very important to understand. This is where, again, I rolled out what is minute ventilation and what is alveolar ventilation. Okay? The reason why you want to know how to calculate both is this is a perfect scenario. 3 different subjects, all 3 of them have a completely different way of breathing. One is hypoventilating, one is hyperventilating, one is breathing normally. And you can see that minute ventilation is exactly the same. So minute ventilation is really not telling you much. It is analogous to cardiac output, right? Cardiac output equals stroke volume times heart rate. Minute ventilation, tidal volume times respiratory rate. But it's really the alveolar ventilation, which is telling you whether an animal or a human is hypo or hyperventilating. Okay? So you actually have to subtract off that dead space. Okay? All right, so in that case, what I probably would give you would be the tidal volume, the dead space volume. I think that there was a question on the problem set, the practice problem set, that'll be very similar. And then you would multiply that by the respiratory rate. So respiratory rate is not giving you information about hyper and hypoventilation. That's the main thing here. Just because you are breathing at a rapid rate doesn't mean that you're hyperventilating, okay? You could be breathing in very shallow, like subject A has a very high respiratory rate at 40, but they're essentially panting, right? They're just bringing enough air in to perfuse the conducting zone where there's no gas exchange. So alveolar ventilation is 0. They're actually hypoventilating. Does that make sense, you guys? Just because they have a rapid respiratory rate does not mean that they're hyperventilating. There's a real distinction. Yes?
And we'll have to calculate this.
Yeah, something pretty similar to this, yeah. Okay, and then you'll have to determine whether you're hyper or hypoventilating. Okay, so that brings us to this slide. Once you decide, after you calculate alveolar ventilation, if they're hyper or hypoventilating, then you'll have to decide what are the gas levels going to be. Okay? Whenever you think about hypoventilation, I want you to think about holding your breath. Okay? That's a perfect example. Yes?
So to determine if they're hypo, you just look for the alveolar ventilation being very low?
Very low.
Okay.
Yep. If you're holding your breath, then it's going to be very low. If you're panting and only bringing in enough air into the conducting zone, it's going to be very low. Yeah. Okay, so what happens when you hold your breath? What happens to oxygen levels and carbon dioxide levels? And you can think about it. When you're holding your breath, you're going to lower your body's oxygen levels, and carbon dioxide is going to accumulate, right? So here's where you are with hypoventilation. Orange line is oxygen, green line is carbon dioxide. Oxygen levels are going to drop, carbon dioxide levels are going to go through the roof. Okay? So to answer any questions, you gotta really think through that. You can even draw this graph if it helps you. Hyperventilation is where, and this is where it's not about respiratory rate, it's about alveolar ventilation being very high. In that case, oxygen levels are going to go up, carbon dioxide levels are going to fall. You're going to blow off carbon dioxide as you hyperventilate. Okay? Okay, so on the exam, if I can give you any piece of advice, don't overthink the questions. They are literally over the plate. So when you think about these types of questions, it's about cause and effect. Okay, 2 steps. Cause, it'll say in the question, what is the cause and what is the effect? What is the compensatory effect? It's not, okay, what's the cause and then the effect and then this is going to happen and this is going to happen and this is going to happen, so I think it's going to be this answer. It's never going to be that complicated. Okay, it's going to be cause and effect. Okay, don't overthink it. Usually, your first answer is the right one. Okay? All right. Then we actually talked about transport, which led us to gas laws. Now, this is giving you some information about concentration of oxygen. So you have 700 mils of oxygen. Remember Henry's law, concentration equals partial pressure times solubility. So when you look at concentration, it doesn't really tell you much about driving force, right? 750 mils of oxygen in the veins, you pick up 250 and now you're 1,000, right? 1,000, 750, and it goes on. But it doesn't tell you driving force. You wouldn't be able to predict which way oxygen is moving, okay? That's where partial pressures are much better because the partial pressure actually gives you some information about driving force. Okay, so in this case, when you actually see the partial pressure of oxygen in the alveoli at 105 and the partial pressure of oxygen in the veins, you can see that there's a driving force now for the movement of oxygen in the alveoli to move into the circulatory system. And then that brings you to a partial pressure of oxygen of 100 millimeters of mercury in the arteries. So knowing how to calculate partial pressure is important. And it's an easy calculation. You guys have done it 1,000 times already with the problem set. Partial pressure is the atmospheric pressure. If you're calculating dry gas, you need to subtract off the water vapor pressure, about 47 millimeters of mercury, and then multiply it by the percentage of that gas in air, in normal air. You guys pretty good with that? So subtract off the water vapor pressure from the atmospheric pressure and then multiply it by the percentage of that gas in normal air. So to calculate partial pressure of oxygen in the air, it would be 760 minus 47, multiply that by 21%. Okay? Yeah?
Do we have to know, like, oxygen and all the percents in the air?
No, it'll be given to you. Yep. Yeah. Okay, so that brings us to this slide. Teaches you how to calculate partial pressure.
There's a problem on number 26.
Yeah. So,
Just so they know.
yeah, number 26, on the practice exam, you're at Pike's Peak. Atmospheric pressure is 450. You need to calculate the dry gas. It's actually in the equation, in the problem. Subtract off, so you'd say 450 minus 47, and then multiply that by 21%. It's pretty straightforward. The answer is 85. Yeah, just picking out that information is important, yeah. The question will say dry gas, then you know to subtract off the 47, and then it actually has 21% right in the question. Okay, so everybody should know how to calculate partial pressure and why it's important. Gives you some information about driving force. Okay, so you are very familiar with Fick's law, right? You know how to think about the diffusion of uncharged particles, but then we added another layer to it. Instead of concentration, instead of the delta C, right? The difference between the concentration gradient outside minus inside. Instead of concentration with gases, we have to use Henry's law. We have to know something about concentration with Henry's law is equal to the partial pressure of any gas times the solubility. So, like Fick's law, we would just plug in, instead of concentration, partial pressure times solubility. Okay? And that gives us information about the diffusion of gas molecules. And why this is important is because solubility matters. Like I said with pneumonia. Pneumonia, you get this accumulation of fluid in your lungs, and it compromises your ability to diffuse oxygen from the lungs to the capillaries, the pulmonary capillaries. Okay, oxygen is a lot less soluble than carbon dioxide. So usually people that have pneumonia have compromised oxygen transport because they can't transport oxygen from the lungs into the blood, but their carbon dioxide levels are normal. Right? They can easily, carbon dioxide can move from their blood out of their lungs. Okay? All right. Don't worry about Graham's law. Graham's law is just giving you more information about diffusion rate. It's combining Fick's law and Henry's law. And you could probably kind of think through this, but there's no question on the exam, so I don't want you to fret about it. I don't want you to be anxious about it. Right? It's just saying that if you combine Fick's law with Henry's law, where you're substituting partial pressure and solubility into concentration, you can write the diffusion rate as proportional to gas, this is the partial pressure, times solubility, that's concentration, times the area, over distance of diffusion, and the square root of the molecular weight is giving you something about radius. Again, Fick's law, right? Radius is a factor. Okay, so it's just a combination of how to think about diffusion of gases. The questions that I would ask are very similar to the respiratory essential calculation sheet. Not anything beyond that. So if you can do those easily, you won't have any trouble. Okay, so let's see. I think we have a few more minutes. I don't think it's going to take us long to go through this one. All of these slides, oxygen, the oxyhemoglobin dissociation curve. Oops, that's the GI tract. There we go. Okay, so you do need to know something about hemoglobin. You guys feel pretty comfortable with ventilation perfusion matching? Okay, just know if there's alveoli that aren't getting any air for whatever reason, maybe a mucus plug, smoker has a lot of mucus plugs, then you're going to divert blood away from those alveoli that are sick. You're going to divert it to more healthy areas of the lung. And vice versa. If there are areas of the pulmonary capillaries that are plugged, then there's going to be bronchoconstriction, so you don't have to ventilate areas of alveoli that don't have any blood associated with it. So there is a diversion of flow, blood flow and airflow away from local areas of disease to healthy areas of the lung. That's called ventilation perfusion matching. Okay, so I'm just going to go to the important things. I think this one is telling you that there's a real difference between partial pressure of oxygen and carbon dioxide. In this case, we're looking specifically at oxygen. Remember, that is soluble oxygen. Okay, so soluble oxygen is what's contributing to the partial pressure. Hemoglobin changes the partial pressure in one compartment. See how you've got pure water and oxygen? And then you drop in hemoglobin. Oxygen starts to bind with the hemoglobin, and it lowers the partial pressure within that compartment. And then there's going to be diffusion until the partial pressure is equal. Diffusional equilibrium. Okay? So the oxygen that is associated with the hemoglobin molecule is not participating in the partial pressure of oxygen in that area. And somebody, good catch, asked me in class, why are there 6 oxygen molecules for every hemoglobin? There should be 4, right? Good catch. Okay, so then we talked about DPG. Remember, when we're talking about hemoglobin postnatal, usually neonates have 2 alpha and 2 beta, and DPG binds to the beta in adults. Fetal hemoglobin is made up of 2 alpha and 2 gamma, and DPG does not bind to the gamma. Okay, so Bohr effect. I think we can do this pretty quickly. The Bohr effect is anything that shifts these curves, let's just put it right here, to the right or the left? The right. Yes, you said right. Yeah, sorry, I didn't hear you. Anything that shifts, here's the P50, anything that shifts the curve to the right is enhancing the Bohr effect. And how to think about this is basically, when you shift the curve to the right, you're facilitating the unloading of oxygen. It lowers the oxygen affinity. Does that make sense, you guys? So I always think about exercise. When you exercise, just think about this area in your quads. When you exercise, you're going to increase carbon dioxide, increase temperature, increase lactic acid. All of those are going to shift the curve to the right. See, with the pH, you can actually see 7.6, 7.4, 7.2. As you become more acidic, you shift it to the right, and then when a red blood cell, when hemoglobin enters into that area with high carbon dioxide, high acidity, and high temperature, it lowers the affinity of oxygen, that hemoglobin, and it unloads easier. It facilitates the unloading of oxygen. It makes a whole lot of sense. That's called the Bohr effect. And that happens with pH, carbon dioxide, and temperature.
And DPG.
And DPG, right. So that's a really good one too. So DPG. Now this graph is a little bit harder to read because what it's doing is P50 is on the y-axis. So as you increase P50, what you're actually doing is you're shifting the curve to the right. So let's go back to this one. See? Here's the P50, and if you read down, that's about 5. As you shift it to the right, we're at 10. As you shift it more to the right, we're at 25. As the P50 increases, you're shifting that curve to the right, facilitating the unloading of oxygen. So this one is a harder one. It's like a two-stepper, right? As you increase P50, you're shifting the curve to the right. So this is just saying as you increase the level of DPG, you're shifting that curve to the right. So it's a cool story because when you're talking about maternal hemoglobin versus fetal hemoglobin, let's see. I don't have a good... Let's just imagine instead of temperature, this is DPG. Okay, so as you increase the levels of DPG, you shift this curve to the right. So this would be high DPG levels, and this would be low DPG levels. Okay, so fetal hemoglobin, low DPG levels, has a very high affinity for that oxygen. Doesn't give it up very readily. High affinity. Maternal hemoglobin, when there's lots of DPG, they tend to give up that oxygen molecule a lot easier. So it's a great story because now the maternal hemoglobin and the fetal hemoglobin don't compete. Right? Maternal hemoglobin comes into the area where there's exchange, the placenta. Right? Here's the exchange that occurs. This pool of blood is the maternal blood. These vessels right here are the fetal blood. So here's where it all is exchanged in the placenta. And the transfer is easy. Mother's hemoglobin gives up the oxygen readily, very easily. Fetal hemoglobin hangs on to it really tight. All right. Root effect. This is giving you some information about the saturation. The saturation tells you something about total oxygen carrying capacity, just like carbon monoxide, right? So when you lower this saturation point, you're actually lowering the total oxygen carrying capacity. And pH in eels tends to be, this is called the root effect. It doesn't just shift the curve to the right, it actually lowers the total oxygen carrying capacity, called the root effect. And you saw this graph when we were talking about carbon monoxide last Friday. All right, and then you guys, I can tell you right now, since Lily, this was in the practice, or this one? If this is in the practice, then this is on your exam. In other semesters, if this is on the practice, then this is on your exam. So just know how this works. This is called the Hamburger Effect. Carbon dioxide is produced by the tissue. It diffuses into the red blood cells. Some of it binds to hemoglobin, but the rest of it reacts with water. The carbonic anhydrase actually converts it to carbonic acid, which then is broken down into hydrogen, binds also to hemoglobin, and bicarbonate. Bicarbonate accumulates in the red blood cells, and then it drives the exchanger, forcing bicarbonate out and bringing chloride in. This is also called the chloride shift. So 70% of all carbon dioxide that's transported from the tissue to the lungs is transported in the form of plasma bicarbonate. 70%. Most of the bicarbonate is forced into the plasma, and then it's transported back to the lungs in the form of plasma bicarbonate. So then it gets to the lungs, right? And carbon dioxide actually starts to diffuse out, which lowers the carbon dioxide levels in the red blood cells, right? It starts to drive the reaction in the opposite direction. So now you start to lower bicarbonate in the cells, and that's going to drive the exchanger in the opposite direction. Bicarbonate is going to be forced in, fluoride is going to be forced out. As bicarbonate accumulates, it's going to react with the protons, be converted to carbonic acid, and then be converted to more carbon dioxide, which is going to be forced out into the lungs. Does that make sense? It's called the Hamburger Effect. It's actually super elegant, the way this equation, these reactions occur in the red blood cells. It helps to increase carbon dioxide transport. It helps to maximize the amount of carbon dioxide that can be transported from the tissues to the lungs. All right, last thing, peripheral chemoreceptors. So this will help you kind of with the acid-base regulation. Just know that you have chemoreceptors are going to sense carbon dioxide, acid, and very large changes in oxygen. You have to go to pretty great changes, decreases in oxygen for this to be triggered. But this is called, so it's mostly sensitive to carbon dioxide. One way to remember this, you guys, is if you've ever been snorkeling or diving, this is mainly free diving, where you just have a snorkel in your mouth. Have you ever been in a pool where you actually have stayed, you're trying to have a competition with your friend who can stay under longer, right? When you're down there for 2 minutes, 3 minutes, all of a sudden that urge to breathe gets really great, right? You try to stay down there as long as you possibly can. You're accumulating carbon dioxide in your body. You're triggering these peripheral chemoreceptors, and that urge to breathe is going to get really strong, okay? Your body's very sensitive to changes in carbon dioxide, not so sensitive to oxygen. The central chemoreceptors, they respond, they're stimulated by increased CO2, by associated changes in hydrogen ion concentration. So you have a blood-brain barrier that doesn't allow for hydrogen ions to move across. So what happens is carbon dioxide can easily move into the brain, and then it's converted to hydrogen. Then it's converted to acid, and then it's triggering the changes in the respiratory rate. So the central chemoreceptors in the medulla oblongata are triggered by a slightly different mechanism, but the end result is the same. Small increases in carbon dioxide, changes in acidity, and large decreases in oxygen. All right. This is just information that goes along with the carbon monoxide worksheet. Hypoxia is basically inadequate oxygen delivery to the tissues. And that can happen in a number of different ways. The first one is anemic hypoxia, poor oxygen delivery because of a lack of red blood cells. So a lot of times this is due to iron deficiency. If you don't have iron deficiency, or you've recently been injured or lost a lot of blood, that can cause anemia. And as we know, most of the oxygen transported in your body, 98%, is bound to hemoglobin. So that's important. Ischemic hypoxia is when there is some kind of blood circulation is impaired. So what that means is in the heart, you can cause ischemia if you have blocked blood vessels. cholesterol builds up, it blocks the coronary arteries. You don't get blood to certain parts of the heart, and it causes necrosis. It causes cells to die. That would be ischemic hypoxia. Histotoxic hypoxia is more like cyanide. You have plenty of oxygen that's circulating in your body just can't use it. Cyanide affects the ability for that electron transport system. Oxygen is that last step. It doesn't allow for you to use the oxygen that's circulating. Causes blue lips. And then reduced arterial O2 is like when you're at high oxygen or you have COPD. Okay, you guys, I think that's pretty good. Do you guys feel pretty comfortable with the acid base and how? I think with acid base, it's just really important to remember that it's only one step. I'm going to ask you the cause or the effect, okay? So if you are hyperventilating and you cause your blood pH to rise, right? Because if you're hyperventilating, you're going to blow off a lot of CO2. That's going to change the blood pH. pH is going to rise. What would you call this? Would this be a respiratory acidosis or a respiratory alkalosis or a metabolic acidosis or metabolic alkalosis? If the cause is hyperventilation. It's definitely alkalosis, but it's caused by the respiratory system. So if it's caused by respiratory issues, then that's going to be a respiratory alkalosis. If it's caused by, let's just say, vomiting, then it's going to be a metabolic alkalosis. Or if you ate a bottle of Tums, then it's going to be a metabolic alkalosis, okay? Respiratory acidosis is going to be caused by holding your breath, right? Or COPD, right? Something like that. That's a respiratory acidosis. If you drank too much acetic acid, vinegar, or citric acid, then you're going to cause a metabolic acidosis, okay? So the cause is what you're looking for. I will give you that sheet that gave the pyramid. That, yeah, you'll be able to kind of deduce that if need be. All right, you guys. Thank you for coming. I'm going to go ahead and stop it.